I'm going to introduce Dr. Avril Moodley. She's a dynamic specialist obstetrician and gynecologist. Her journey in the medical field began with her graduation from Walter Sisulu University in 2004, and her love for obstetrics and gynecology was solidified during her community service in Ermelo, Mpumalanga. She has years of experience working as a senior medical officer in obstetrics and gynecology and pediatrics at Wentworth Hospital and Chris Hani Baragwanath Academic Hospital. Dr. Moodley went on to specialize at the University of Cape Town, where she became a fellow of the College of Obstetricians and Gynaecologists in 2012. Dr. Moodley went on to obtain a Master of Medicine in Med degree from the University of Cape Town in Obstetrics and Gynaecology in 2023, achieving distinction in the dissertation component. In 2023, she qualified as a Menopause Society certified menopause practitioner from the formerly known North American Menopause Society. Since 2013, she has been in private practice, dedicating her career to helping women achieve optimal health. With her passion and expertise in women's health and preventative medicine, Dr. Moodley is committed to providing exceptional care and support to empower women. Thank you so much, Dr. Moodley, for coming.
Thanks, Liam, for that lovely introduction. So I'm going to basically do a crash course on menopause. It's going to be fairly basic, but filled with tons of information. Okay, when we look at menopause, it's defined as a retrospective diagnosis 1 year after the last menstruation. And nearly 40% of women live their lives in the postmenopausal period. So for women all over the world, this is why menopause matters. If we look at the definitions and terminology, it's important to remember that primary ovarian insufficiency is a diagnosis that must be made separately if you have loss of ovarian function before 40 years of age and not treated as a menopause patient. Also, the perimenopause or menopause transition or climacteric has the same definition where you see changes around the just prior to menstruation and 1 year after your last menstruation. The straw plus 10 classification is what we use to classify a woman in her staging cycle of life. And this is we look at the late reproductive area, the menopause transition, as well as in the early and late period, as well as the postmenopause period of early and late. And this is not defined by an age because women are different and menopause occurs in different age groups. The principal criteria is thus the menstrual cycle as our main criteria, and most women can be staged according to this. If we look at the supportive criteria of FSH levels being one of them, it is variable from stage 3A, which is your early reproductive stage, to your early postmenopause, and there are constant fluctuations in your estrogen levels, which make it a unreliable result and is thus not done routinely. So the criteria is not applied if there's a history of primary ovarian insufficiency, irregular menstrual cycles, hysterectomy, or endometrial ablation. Vasomotor symptoms, one of the most commonest symptoms women experience, and probably the only known symptom to most people. It's also the most bothersome symptoms that affects quality of life and can be very debilitating. If we look at the pathophysiology of vasomotor symptoms, it's mostly our KNDy neurons, which is your kisspeptin, neurokinin 3, and dynorphin, which stimulate and inhibit your NK3 receptors, causing the hypothalamus to create a hot flush. You have your GnRH, which is released from the hypothalamus, stimulating release of LH and FSH from your pituitary, and that causes your gonads to release estrogen. Gives you a positive, negative feedback on the KNDy neurons, which then stimulates a hot flush. This is a short video clip explaining the preoptic area of the hypothalamus. There's your candy neurons. You can see estrogen in blue and the neurokinin 3 in orange. Your estrogen attaches to your receptors, inhibiting the candy neurons. And then you get your neurokinin 3 B, which attaches to the NK3 receptor. And when this attachment occurs, when your neurokinin, okay, this figure is not working. Okay, there we go. Okay, so I'm just going to explain this video. When your neurokinin B attaches to the NK3 receptor, which is the orange one, it stimulates and creates a heat dissipation. There we go. Onto a thermoregulatory center in the hypothalamus. You get, this is my first video, you get a heat dissipation and triggers your hot flush. If we look at the risk factors for vasomotor symptoms, this is what makes women, some women experience more severe hot flashes than others. Obesity, smoking, alcohol, and then oophorectomy is one of your major factors. Always remember that not all vasomotor symptoms are related to menopause, and you should rule out other medical diagnoses. If we look at the recommended evidence-based non-hormone therapies, weight loss is, this is based on randomized controlled trials that have shown significant benefit. Weight loss improves vasomotor symptoms for your mild to moderate patients. Hypnosis, clinical hypnosis done by a trained professional, something we don't have a lot of in South Africa, works well. But our biggest one, cognitive behavioral therapy, is a large, currently well-renowned tool that's used for vasomotor symptoms, stimulating the brain on how to deal with it. A stellate ganglion block, that is an invasive procedure done by anesthetist, which is generally not done. Antidepressants, we normally use SSRIs or SNRIs. Your fezolinetant, which is the new kid on the block, the NK3 receptor antagonist, which actually blocks your NK3 receptors, like the video I just showed, which then actually stops your hot flush. Your gabapentinoids and oxybutynin. Just to note that oxybutynin works well for moderate to severe hot flushes. However, long-term use does cause significant cognitive decline. If we look at the second silent killer, though, the number one cause of death amongst midlife women is your cardiovascular disease. This is the formation of atherosclerotic plaques, your mitral incompetence, and your aortic stenosis. Now, most of the reasons for mortality is based on what happens in the vascular, within the vascular walls, and this is where you increase in LDL, triglycerides, apolipoprotein B, your endothelial dysfunction causes atherosclerotic plaque formation, which then results in most commonly your MIs. If we look at the staging of women from childhood to menopause, I just want to mention that polycystic ovarian syndrome, infertility with recurrent pregnancy loss increases your risk of cardiovascular disease. And within the last 5 years, the cardiology associations have now listed 5 conditions in pregnancy that significantly increase it. Your hypertensive disorders of pregnancy due to endothelial dysfunction, gestational diabetes with a 2 times increased risk of cardiovascular disease, preterm labor increasing cardiovascular disease by 3 times in a woman, growth restriction, and then just to note that weight gain in pregnancy of more than 15 to 20 kilograms has an increased risk factor for cardiovascular disease. The lack of breastfeeding, so if a woman breastfeeds for up to 1 year, there's a 13% reduction in cardiovascular disease. And in these women, consider statins early to prevent long-term morbidity and mortality. Our second symptom, or not always symptom, is cognitive health, where we get our brain fog. This is quite important for not just the woman, but for their family around. And what we know about estrogen is that it improves blood flow, it's an anti-inflammatory, improves growth factors as well as synapse formation. So for menopause, decreased concentration and memory loss occurs because of the loss of estrogen. If you add risk factors to this, like diabetes, hypertension, obesity, smoking, and sedentary lifestyle, you can progress to a form of dementia. In your brain, you have multiple GLP-1 receptors, which helps clear out the tau tangles and amyloid plaques when insulin enters into the cell, causing in Alzheimer's disease, you get downregulation of these receptors. And my only warning for NATO is your neuroinflammation, apoptosis, amyloid plaques, tau tangles, and oxidative stress. Most women will have a transient cognitive decline, which is brain fog, and it resolves after a short period of time. And a bilateral oophorectomy at 45 years or younger has a significantly increased risk of dementia, which should be prevented. Just to note that 40% of dementia cases are preventable. And if we look at hearing loss being 8.2%, we should remember to ask this question about hearing loss and treat as soon as possible. Brain health. What helps improve brain and cognitive function? It is both physical exercises as well as mental exercises, so stimulatory memory games, puzzles, and higher education status decreases cognitive decline because it prevents brain cell apoptosis. And then you have physical exercises, which releases irisin from the skeletal muscle, causing neuroinflammation in the brain, but preventing neuroinflammation. When we look at our sleep and mood disorders, sleep hygiene techniques are not always useful for these patients. And just to note that no form of hormone therapy is approved to treat insomnia. However, if the insomnia is related to the night sweats and vasomotor symptoms that's waking up a patient, a woman's going to wake up sleepy and tired, then become moody, and then relieving these vasomotor symptoms helps with sleep. CBT and non-hormonal pharmacological treatments like exercise and acupuncture is useful. And then always remember to refer to a neurologist and a sleep study if you are suspicious of obstructive sleep apnea, which is CPAP is useful for, or restless leg syndrome. Non-hormone interventions for mood disorders, antidepressants are generally your first-line treatment. However, psychotherapy is very useful and just needs long-term care. If we look at the pharmacological therapies for your SSRIs and SNRIs, if you have vasomotor symptoms, we use desvenlafaxine with venlafaxine. But remember that higher doses will actually cause hot flushes. And with paroxetine, just remember to avoid it in your breast cancer patients on tamoxifen. Your benzos and Z drugs, long-term use causes cognitive decline. So it's important to just remember to try and get them down off medication as soon as possible. When we look at our muscles and joints, due to the same estrogen effects on all cells of the body, there's decreased blood flow, inflammatory response, loss of cartilage formation, and sarcopenia. So you get arthralgia. This is normally mild and responds well to non-steroidal anti-inflammatories. If, however, you are not having any improvement, consider chronic other diseases that are chronic in nature, especially things like your autoimmune and rheumatoid arthritis. Osteoporosis, prevention is always better than cure. And for women, we know that menopause is a significant area where bone resorption occurs, and a decrease in low bone density, as well as microarchitectural deterioration. If you look at the picture of a normal bone and then an osteoporotic bone. Just to note, when we do DEXA scans, it doesn't always look at total bone score. So nowadays we have DEXA scans with TBS, which looks at microarchitecture and can differentiate. And sometimes patients have a normal DEXA, but you can start them on treatment because of deteriorating microarchitecture. Bone loss is marked in the menopause transition and the early menopause period. And remember that long-term use of PPIs increase fracture risk. If we look at the genitourinary syndrome of menopause, this is something that is more long-term and progresses and worsens as time goes by. Women don't generally present with these symptoms to you. You see it on examination, but examination doesn't mean treatment. They have to be symptomatic before you treat them. If we look at the pathophysiology and estrogen blood flow to the vaginal tissue, the collagen stimulation and mucopolysaccharides, it maintains a pH of less than 4.5 and creating a healthy microbiome. However, when the estrogen receptors, which are found throughout the genitourinary tract, are decreased, and because of your estrogen levels, you get atrophy, and you can see the comparison pictures between normal to postmenopausal patients. You get thinning of the muscle walls, increase in inflammatory responses and vaginal discharge, and your introitus and your urethra opening become quite close, which is generally why most women present with dryness, vaginal discharge, and recurrent urinary tract infections as your common symptoms. Always remember there's other causes besides GSM, so make sure you have managed to rule them out. The non-hormone therapies are lubricants, moisturizers, pelvic floor physiotherapy, and dilators. Just to note that your other considerations, vaginal laser therapy, very massive in the aesthetic world. In the randomized control trials that were done, the effect was very similar to sham trials. Hormone therapies for genitourinary syndrome, we normally use topical estrogen, normally through creams or a vaginal pessary tablet that is inserted. It's a localized estrogen. It can even be used with the oncologist acceptance on breast cancer patients because the systemic absorption is very minimal, and breast cancer patients tend to have a lot more atrophy because of the radiation that they sometimes undergo. With regard to pelvic floor dysfunction and sexual dysfunction, the pelvic floor and your muscles, your levator ani muscles, support both your spine and pelvic skeletal system, as well as your intra-abdominal organs. And with time and risk factors like previous seizures or surgery, endometriosis, you can get a hypertonic pelvic floor. And with long-term obesity, constipation, multiple vaginal deliveries, you can get a hypotonic pelvic floor. Pelvic floor physiotherapy works amazingly well on these patients. Needs to be started early and continued to prevent long-term problems. With sexual dysfunction, I'm not going to talk about it here, but just to note that sexual desire, arousal, orgasm, and pain disorders are strongly associated with significant problems with relationships, and this should be addressed, and a provider that is aware of these different symptoms should be able to manage it appropriately. Skin and hair to women, this is probably the most important thing to them. There's hair loss as well as thinning of the hair and brittle hair. And with your skin, aesthetics, to a woman, beauty is everything. So if we look at the factors affecting skin changes, you've got your intrinsic and extrinsic factors. Extrinsic is probably the things we can try to reduce, especially for long-term aging. In the pathophysiology, you've got decreased fibroblast activity, elastin and GAD production. That is your plumpness, your elastic, your nature of your tissue that's reduced. Your melanocyte is what creates your brown and red spots and your pigmentation, and your decreased blood flow, cellular growth, which causes the thinning of the skin, your lipoatrophy, fat pad, and bone resorption, which causes basically that loss of bone tissue in your cheekbones and your sagging face as a woman gets older. There's a 30% decline in skin collagen in the first 5 years after menopause and a 2% decline over the next 20 years. This is what we call the triangle of aging, where a young woman has high cheekbones and creates an upside down triangle. And as you get older, because of these changes, you get a right side triangle. Sunblock, something we should tell all women when we see them at an early age, is to reapply. There's UVA, UVB, as well as blue light, and this will significantly reduce the effects of aging later. Refer to an aesthetic physician if needed, especially if the patient and the woman has mood disorders, because improving her skin, you will probably improve her quality of life and make her happier. Retinoids is one of the things we do. Regret is when patients put permanent fillers, and this includes breast implants, where they basically stay the same. And as a woman gets older, their skin doesn't stay the same and it changes. So you're forever getting contouring and distortion around the permanent fillers. Minoxidil is what we routinely use for women's hair, where you use topical ointments on the hair. They don't tend to use this long term because of the oiliness, that they don't want to walk around with it. So we use the minoxidil tablets, and the dermatologist referral for PRP or red light. Weight changes, there's redistribution of fatty tissue, which increases around the abdominal circumference, loss of lean muscle mass, and slowing down of metabolism. However, this is related to the secondary effects of menopause, and weight loss is not menopause a cause or hormone therapy. So you go from an owl body glass shape to a pear or apple shape. If we look at the investigations, your hormone concentrations are too variable and don't stabilize until 3 to 6 years after menopause. So doing these levels is unreliable and not warranted. However, if they meet stroke criteria, you would then use them. Lipid profile for your cardiovascular disease, and this can be started as soon as possible, even at the age of 20 with a family history. Your fasting glucose levels for diabetes, your HB and FBC for iron, and for the iron studies for anemia, and your liver and kidney function test if you're assessing whether treatment is an option. Thyroid function tests, also commonly misdiagnosed as menopause symptoms, so it's important to do it on an annual screening basis. Urinary saliva hormone testing and serum saliva of estrogen is not recommended. It's unreliable and not a true reflection of blood levels. And androgen concentrations are not recommended because we have no defined female androgen insufficiency levels. Cervical cancer screening, which is normally your HPV screening that we now do. We're doing away with cytology, endometrial ultrasound for measuring endometrial thickness before starting a patient on hormone therapy, as well as to rule out pathology. Your ECG for cardiac, your bone mineral density with TBS for osteoporosis prevention, your mammogram and breast examinations. Remember that mammography with highly dense breast tissue is not sensitive, and you should screen earlier because it can miss a breast cancer. Colon cancer screening, now apart from colonoscopy, we do have Cologuard and fecal occult blood, and then remember to screen for urine loss in the required patients. DHEA supplementation, the SWAN study shows that there's a well-established age-related fall in the circulating levels, and thus the studies show that there's no improvement in sexual symptoms, lipid profile, glucose weight, or bone mineral density, and supplementation is not routinely recommended. 5 W's for prescribing MHT. We have who would you prescribe it to? MHT is menopausal hormone therapy. It's the new definition we use. We do not use the word HRT anymore. That's been removed from the system. What patients, what options would you use? Which routes would you use it in? When would you start it? When would you stop it? Why would you use it? And or where would you get it from? And this brings us to the indications for menopausal hormone therapy. So the primary indication is moderate to severe vasomotor symptoms, the prevention of osteoporosis in postmenopausal women. Remember, it's prevention and not treatment, and treatment of hypoestrogenism caused by hypogonadism, like your bilateral ovarectomies and your primary ovarian insufficiency, as well as your treatment for GSM, which can be either systemic or local. Your contraindications are your unexplained vaginal bleeding, estrogen-sensitive cancers, triple-negative breast cancer, history of coronary artery disease, stroke, or MIs, inherited high risk for VTE or history of VTE, severe active liver disease, and peanut allergy. Just to note that not all hormone therapy formulations have peanuts present in their formulation. We should start MHT before the age of 60 and within 10 years of menopause. The most appropriate route with the lowest effective dose for the shortest duration is what you want to get. If we look at the categories of hormone therapy, you've got your estrogen therapy on its own, which is your unopposed, and this you would use on a woman without a uterus. Your estrogen-progesterone combination for endometrial protection on a woman with a uterus, your T-sex tissue-selective estrogen complex for women who prefer not to use a progestogen, and your selective estrogen receptor modulations, which has different effects, agonist and antagonist at different sites. So when we look at the types of estrogen, our conjugated equine estrogen is what we've been using since the 1940s. This is made from the urine of pregnant mares. It's 7 times more potent than human estrogen. Your micronized 17-beta estradiol, which is the only bioidentical estrogen, which means it's similar in structure to your endogenous estrogen, ethinyl estradiol, which is used in your COCs, and esterified estrogen, which is a synthetic mix of estrogens. And also a new kid on the block is estetrol, which is formed from fetal liver during pregnancy, weaker form of estrogen with less adverse effects, currently used in the combined oral contraceptives. If we look at the routes, I'm not going to talk about the localized effects because we did that with GSM, but your systemic for oral versus transdermal routes. So I always wonder, why do we have oral when transdermal is a much safer option with much significant less adverse effects? Some women prefer oral tablets, and it can benefit with glycemic control in diabetics. However, diabetics tend to have other risk factors which can make transdermal route better. This is your patches and your gels. With oral routes, you have first pass metabolism, so you have increase in your cholecystitis and pancreatitis because you've got stasis of the gall, increased secretions of in your gallbladder and decreased motility. You have an increase in sex hormone binding globulin, which causes a decrease in your free testosterone and causes libido. You have your increase in coagulation factors, which increases your VTE risks. And this is what makes transdermal route a little bit more a better option for less adverse effects. The type of progesterone therapy, you have micronized progesterone that's now bioidentical or body identical, and your progesterones, which are your synthetic components that are progesterone-like, and your synthetic components that have testosterone activity. The alternative forms are your Mirena, which is your levonorgestrel intrauterine system for endometrial protection. Your SARMs, just to note that you have estrogen receptors, alpha and beta receptors, and they can inhibit and be an agonist on these receptors. So tamoxifen being one of them, which is works well for breast cancer, but it's an agonist on your bones, which is good, but it's also an agonist on your uterus, which is why there's an increased risk of endometrial hyperplasia or cancer. When do you start and when do you stop for primary ovarian insufficiency and early menopause? So if women go into menopause before the age of 45, you should start at the diagnosis until the average age of menopause, which is around 48 to 52 years of age, just to reduce their long-term morbidity and mortality. For the menopause or perimenopause period, currently, MHT is only indicated for women in menopause or late perimenopause. But for the women generally in early perimenopause, which has a lot of women having symptoms of vasomotor symptoms, you have an increased incidence of adverse effects if you use it. You would be using it off-label, and because of the intermittent endogenous estrogen concentrations, you tend to have more adverse effects. In these patients, you also generally need a contraceptive, so you can consider using a combined oral contraceptive if it's not contraindicated. Remember that a woman above 40 is already WHO staging 2. So if she has one more risk factor like smoking, obesity, hyperlipidemia, hypertension, she already classifies as a 3 or 4, which is an unacceptable health risk. And then you'd have to use a different form of contraception. There are no arbitrary limits set on when to stop. A personalized shared decision making is important. If we look at compounded hormone therapy, which is what is advertised as bioidentical, bioidentical is a term that's known to be an advertising term and not a scientific term. It's a compound pharmacy that makes these drugs. The studies of the global consensus on menopause hormone therapy shows that the use of compounded hormone therapy is not recommended due to the lack of regulation, efficacy, safety data, purity, as well as the label. Your South African Menopause Society, SAMS, came up with the same position statement, and the North American Menopause Society in 2022 released a similar position statement saying that compounded hormone therapy is not recommended. When we talk about social media, friends, family, media, and internet, we find a lot of views about MHT and why it's good and bad for you. And it is important to note that this comes from the WH trial, which was released in the early 2000s and started in 1990. In this trial, they used conjugated equine estrogen, which is much more potent, and we have much better forms of estrogen. This is the study that showed the age between 50 and 59 years, where we look at women, coronary heart disease, stroke, and breast cancer. In the estrogen-only group actually had decreased incidence, whereas in the combined estrogen and progesterone had an increased incidence. The second problem with the WHI that people are quoting is that if you look at women, the estrogen only and estrogen and progesterone compared to placebo separately, women in the 60 to 69 age group and in 70 to 79 are the women that had severe adverse outcomes. And this is a group of women where MHT is not recommended because we use it in less than 60 years of age. So if you compare the 50 to 59 years group, apart from the significant improvements compared to placebo in certain outcomes like cardiovascular disease, the adverse effects was very minimal. And for the physicians, this is where I'm probably going to get killed. Coronary heart disease, remember that if you started early and within the right criteria, helps to improve and reduce cardiovascular disease. However, if there is already pre-existing atherosclerotic plaque formation and cardiovascular disease, MHT should not be used. Regarding venous thromboembolism, it is an absolute contraindication. However, if you have a patient under off-label use with a woman that had pre-existing long-standing previous history of a thrombosis that was induced by a possible surgery with a long-term bed rest, and the woman has severe hot flushes that's affecting quality of life. You have tried all forms of non-hormonal treatment, including the new NK3 receptor antagonist, and it hasn't resolved. You could, together with the physician and a multidisciplinary approach, as well as the patient consent, use an anticoagulation, a transdermal menopausal hormone therapy until you get some benefit, and then try and stop as early as possible. Sorry, with your diabetic patients, your diabetes oral MHT has better glycemic control, but generally there's other significant risk factors for rather using a transdermal approach. However, with MHT and diabetes, you have better glycemic control with these patients. Migraines, MHT is not a contraindication like your combined oral contraceptives. A transdermal approach is much better, and sometimes they have better relief, especially if it's menstrual migraines. With regards to thyroid disease, it's important when you start and stop MHT that you repeat your thyroid function if a patient is on oral MHT within 6 to 8 weeks, because your oral estrogen increases your thyroid binding globulin, which then decreases your T4. It's also important to remember that when you do a thyroid function, women are very big into skin and hair and are busy taking a lot of supplements containing biotin, and this should be stopped 24 hours before your thyroid bloods are done, because it causes a false reading and that's not incorrectly treating them. Remember that one size doesn't fit all. It's a personalized and combined decision making, and that remember to rule out pathology because everything is not menopause. Thank you very much.
Thank you. I think I'll probably can take over and start treating menopause women because I already have my first course. Thank you for the presentations. It's been, I think you have went through a lot of details. Just have a simple question. Where do our transgender patients fit?
Transgender.
Transgender.
Yes.
So currently transgender is a big thing in the menopause world.
And US too, mostly.
Yeah, and having my qualification from the US, it's one of our big things that you have to watch. It's actually in South Africa, we see a lot of women. And the problem with that is that with transgender populations, they're either taking estrogen to, develop breast and get feminine features. And then you get your males, which are trying to reverse, and you get the use of testosterone. You have to remember that they become much more complicated, and it's not as clearly defined. There is no consensus statements or guidelines on the use. So currently you have to treat each individual patient as their own. So if a male by genetics is converting into a woman, so, and they're taking estrogen, you have to account for all the side effects. What's their routes of treatment? What are you trying to get out of them? Did they have surgery? Did they have counseling? And then you have to make sure that you use your long-term risk profile. There is no studies in terms of their cardiovascular disease, venous thromboembolism risks on these patients as well. So it becomes a lot more complicated in managing them, and it's not a simple answer. You have to treat each individual case on its own in terms of how would you manage them.
Thank you. My last question. We see quite a lot of patients currently at our postmenopause that present with the recurrent urinary tract infections. In relation to that, to menopause, and how do we address it? Because that's majority of population in the midstream. Any insight into that?
Yeah, so if we look at the pathophysiology of the decreasing pH of the increased pH of the vagina and the increase in inflammatory response and the vaginal discharges, you get a microbiome that's not as healthy as you would in your premenopausal period. So what happens with those patients is that with the vaginal atrophy, your estrogen receptors between your urethra, your bladder wall, your vagina, your vulva they all cause thinning and atrophy. And you get narrowing of the introitus. So you're opening between the vagina and the urethra much closer, and you significantly get recurrent UTIs. You do have to remember that you have to exclude other causes of, a lot of times patients are being treated on a localized estrogen, but they are urinary causes that are not related to GSM. However, and you have to do a physical examination. So you never start the patient without examining, because you also don't want to miss a malignancy. So it is important to do a physical examination, but it's probably the biggest reason why I start patients on a localized hormone therapy is recurrent UTI.
I think this is actually very, very important. I think again, personal hygiene become a very big factor during menopause. I think if you look statistically, we see most of the female actually come with go into septic shock. It's quite a very high risk of mortality, actually. I think in South Africa, we don't have our own data, but something to look at. And I think it's probably you just hit the nail on the top by saying that you explain pathophysiology quite clear here. Any question online on the floor? Yes.
As a physician, we often see patients 70 plus, even 80 years old on MHT, and they've been on it for 100 years, and they do not want to stop it, either because they say they've tried and they feel worse when they're off it, they're getting symptoms of withdrawal or whatever. How do you speak to those patients? What should you do? Or if she's 89 years old, do I just let her continue because, of advanced age, or what is the right way to go about it?
Okay, so ideally you want to start before 60, but there's no recommended guideline on when to stop. So technically you can go above 60, but you have to inform the patient that the risk of thromboembolism and stroke increases. If you stop it, you cannot or should not restart it because of your increased risk of side effects. Because once you stop and you start like a new person. If they were continued or maintained on it, their risk of developing adverse outcomes is less likely.
Okay.
However, if you take normal menopause pathophysiology, hot flushes should generally last 5, maybe generally 8, but let's say up to 10 years. So 70 or 80-year-old with hot flushes, you have to consider other causes of hot flashes, and it might not be menopause related. The other thing is we have the new NK3 receptor antagonist. I've been using it off label on a patient on a 74-year-old. She is a Black patient, so Black women tend to have more severe hot flashes. White women tend to have more osteoporosis. So those patients with the NK3 receptor, if you remember that video, you can reduce their hot flashes in a non-hormonal way and improve their symptoms. It can be used on an older patient as their liver function is working well. On my patient, I've been using it probably about 6 months now. She has found a significant improvement. It's just that it's Section 21 criteria. It's off label at the moment, but it is going to be launched soon, probably in March the next year. So if you wait until then, we'll probably have a good option to explain to patients. But if they refuse, and if you document that, and if you can put it down on paper, you are allowed on shared decision making to continue.
Okay, thank you so much.
And
would you recommend estrogens for all perimenopausal?
Okay, so on the randomized controlled trials, you're not randomized on your SWAN study and your HERS trial, found that it actually has no benefit or improvement. So they're very weak estrogenic effects. You can use them, but they will not treat someone with moderate to severe hypertension.
And the PPIs? You mentioned the PPIs.
For increased fracture risk and dementia risk. So long-term PPIs are noted to cause cognitive decline as well as an increase in fracture risk. And that's why normally PPI should be of a short duration, normally 6 weeks with H. pylori. But however, if your risk factors for a patient is significantly high of a ruptured peptic ulcer, for instance, then continuing the PPI might be important. But just repeating scripts that sometimes people do when patients don't need PPIs, that's probably something that should be reassessed.
And when should you start a bone density review?
Okay, so the guidelines are different to my opinion. South African guidelines are not really there, but international guidelines are from 60. I find that I start screening them from 45. At 60, you missed the boat, they've already had a fracture. I start screening high-risk patients from 45. Your POIs, your early menopause, you start screening early. I mean, it's once in 5 years, unless you've got osteopenia. And between 45 and 50, I have found so many patients with osteopenia that you can actually prevent before even having to use your bisphosphonates or any of your anti-resorptive drugs.
Dr. Godinho, in terms of the, I know that you present quite a lot about osteoporosis. In terms of BMI, black patient-wise, you think 45, 50, 60? What's your intake? Can you add to what Avril just said?
I agree, because I think that, it's by the age of 60, you often, have advanced osteoporosis, and then, then you're treating it. With regards to BMI, low BMI is associated with osteoporosis, and increased BMI is more predictive.
Any question online? Okay, if there's no questions, I think we're ending exactly 8:02. Sorry for the hiccups, but I think it's been beautiful presentation. Dr. Moodley is it's available at the Midstream Mediclinic, room number 214 at the Medical Field Building. And you guys can phone for appointment and all this. And clearly, you could listen to podcasts. The podcast is available also online. Yes, thank you.